Hey, we're going to be discussing the chapters covering eyelid and orbital disorders in children in this most current volume of the BCSC. Past volumes have some information from the chapters on orbital tumors and infections as well. There's going to be a lot of information in this talk. There's almost 60 slides, but the three big areas I want you to concentrate on by the end of the session, you should be able to list and recognize 6 congenital lid anomalies, and we'll go through those. Develop a treatment algorithm for patients with congenital ptosis, and then describe the evaluation of a child with proptosis. So I'm breaking this talk into 4 sections: congenital anomalies, ptosis, eyelid lesions, and orbit. When we talk about congenital anomalies, there's a few terms that are helpful to keep us all on the same page. Malformation is simply a morphological defect present in an early stage. So here we have a Chiari malformation with the cerebellar tonsils below the foramen magnum. A sequence is where there's a single defect early in development that leads to a cascade of secondary anomalies. So here we have low-set ears and retrognathia with Pierre-Robin sequence. There's a pattern of multiple malformations with a single cause. So here you have fetal alcohol syndrome with characteristic facial dysmorphia. And then finally, an association is a group of defects that tend to occur together. Here we have iris colobomba, low-set ears, and a high palate. When we're discussing lid position, orbit position, we have lots of terms, and there's some overlap, I think, in different literature here. What I think is probably important is noting that you can base the facial configuration based on inner canthal distance, interpupillary distance, and outer canthal distance. The common terms we tend to use are hypertelorism, where the orbits themselves are actually further apart, so the interpupillary distance is high, and that can be separated from telecanthus, where the interpupillary distance is normal, but the intercanthal distance is high. Okay, with many of the congenital lid anomalies, it's helpful to know the Greek bases of the terms and what they mean, so we'll go through those in the next few slides. With cryptophthalmos, I'm sorry, the Greek letters didn't come in through the slide here. Crypto means hidden or secrets. This is a orbit that has a globe in it. Might not be a normal globe, but there's a globe there. But the lids are fused over top. So if you were able to separate the skin, you'd probably find a normal globe underneath or a somewhat normal globe underneath. A more common congenital anomaly is ankyloblepharon. I've seen a number of these in my practice. The lid skin is fused in the upper and lower lid with this web across the eye. Ankylo means hook or joint. Management of this is actually fairly simple. You can use a Westcott scissor to cut across this and the lids will separate. Epiblepharon is also a very common congenital anomaly of the lids. Here, a fold of skin is forcing the lashes back onto the cornea. Luckily, most kids' lashes are fairly soft, so they don't get any corneal defects with this. If they do start having corneal decompensation, you can do surgical repair of the epiblepharon. Euryblepharon, Uri means wide or broad. This is where the lateral lid is lax and droops down. They can sometimes have exposure from this configuration. The blepharophimosis syndrome is a very testable syndrome, so it's helpful to know the components of this. They have ptosis. They have blepharophimosis, where the distance from the inner to outer canthus is short as well, and then epicanthus inversus with a fold from the lower lid up to the upper lid. These patients can have surgical repair in a number of different ways. Some as simple as just doing frontalis sling, and other ones with major revisions of the medial canthal structures. Again, this is a familial disease and is often on test, so be aware of the characteristics. Our last congenital anomaly is dystichiasis. This is where lashes grow in an area behind the normal lash line, often coming from the meibomian glands. The next topic we're going to cover is ptosis. There are a number of factors to evaluate in patients with ptosis. Probably the most important one is levator function. Again, this is measured usually with a clear ruler, patient looking into far down gaze, fixing the brow so there's no frontalis effect there, and having them look up, and measures the excursion of the upper lid. That's shown in the top left picture here. Other measurements you can do is the palpebral height, which is in the top right picture here of number C. Margin reflex distance is B, and then the height of the lid crease, which is A. The things I look for in patients with ptosis is to make sure there's no neurogenic causes like Horner syndrome, which is the bottom left picture, or third nerve palsy, which is the bottom right picture. Two other diseases to consider as well would be myasthenia gravis or chronic progressive external ophthalmoplegia. Those are both more rare, though.
Good. So Michael has Marcus gun, jaw winking, form of ptosis, where the third nerve and the second nerve is interlinked, and when he chews,
We're going to move on to eyelid lesions. Chalazion are fairly common in my practice. It's a blocked up meibomian gland. You can either present anteriorly, like in the top left picture, or posteriorly in the bottom right picture. Management, this can be warm compresses, lid hygiene, topical antibiotic steroid combinations, supplementing with omega-3, fish oil or flaxseed oil, and finally surgical correction if those measures fail to improve things. You've all probably done this a number of times: Chalazion clamp over, incision, curettage. Sometimes we'll inject a steroid in the supratarsal space. If it presents anteriorly, sometimes you have to go through the skin side because it's often ruptured when you put the clamp on, but you try to do it through the back side if you can. Molluscum is a fairly common lid disease as well. It's due to a virus. These can cause conjunctivitis if the virus is shed onto the eye. Management can be conservative or surgical. Surgery can involve either curetting it out, applying cautery, or some people even advocate using clear nail polish to get these to regress. Here's a histological slide of molluscum, gross or lower magnification in the top left, and higher picture with inclusion bodies in the lower right. Lid hemangiomas are also fairly common. It's a benign vascular proliferation. Some people think it's actually ectopic placenta due to surface markers. It tends to be in the upper lids and tends to involute by the time kids are 3 or 4 years old. If it is causing either amblyogenic ptosis or astigmatism, being treated with either oral propranolol or topical Timoptic, can get these to shrink down. Often observe these until kids are 3 or 4. If there's still some hemangioma present, you can do topical Timoptic at that age. Port wine stains can be associated with Sturge-Weber syndrome. Even if it's not associated with Sturge-Weber, sometimes it can cause glaucoma as well. One of the more sensitive things I find is if there is episcleral venous dilation, that's a risk factor for glaucoma, but all these patients should have their pressures checked routinely. The last section we're going to talk about is pediatric orbit. And the first topic we'll talk about is craniosynostosis, including golden heart syndrome. Craniosynostosis is the premature closure of skull sutures. When it affects the calvareal sutures, you get an abnormal skull shape. When it affects the skull base sutures, you get mid-face and orbital abnormalities. One general rule is when a suture closes prematurely, the skull will continue to grow parallel to that suture, but not perpendicular to suture. So if you look at the top right picture of sinusotic scaphocephaly, scaphocephaly means boat-shaped head. The sagittal sutures close prematurely. The skull will continue to expand parallel to the sagittal suture, so it's growing anterior-posteriorly, but does not grow horizontally side to side. The most common non-synostotic cranial malformation is golden heart syndrome. So this is not a premature closure of the sutures, but is an abnormal skull shape, typically with facial microsomia. The ocular findings with golden heart syndrome include limbal dermoid, which we see here. These tend to be present inferiorly or infratemporally. Often they don't need any surgical management unless they're causing a lot of astigmatism or encroaching the visual axis. Another thing that can happen is they can have Dellin formation anterior to the edge of these because of abnormal tear dynamics. A second common ocular malformation with Goldenhar syndrome is dermolipoma. These tend to be temporally as well. And again, I usually leave these be unless they're causing cosmetic problems. These tend to extend far back into the orbit. If they do encroach into the palpebral fissure, you can take the conjunctiva up, resect the dermolipoma, which is deep to this, and then close the conjunctiva. Next is orbital infections. Orbital cellulitis is fairly common in the pediatric populations, usually due to spread from the adjacent sinuses, either the ethmoid or maxillary sinus. These patients have proptosis, lid swelling and erythema, limited globe rotations. In the worst case scenario, they'll get optic nerve compromise. They're typically treated with broad-spectrum antibiotics, with or without sinus drainage from the ENT folks. Imaging these patients will typically show pacified sinuses as well as subperiosteal abscesses. Next, we'll cover orbital neoplasms. There are a number of different orbital malignancies in children. The most important and probably most common are rhabdomyosarcoma and neuroblastoma. A typical history of rhabdomyosarcoma is a child in the 5 to 7-year-old range who had incidental trauma and then started developing proptosis and bruising around the orbit. They can be quite advanced, and if not taken care of in a timely manner, may require orbital exenteration, like the bottom right picture here. There's a number of different type of histological features to rhabdomyosarcoma that should be reviewed. Epithelioid in the top right is probably the most dangerous and advanced type, whereas embryonal, the bottom left, has the best prognosis. Neuroblastoma is the most common orbital metastases. It typically is in younger kids. It either arise from the adrenal or from the sympathetic ganglion. Metastatic neuroblastoma tends not to cause Horner syndrome unless it's arising from the sympathetic ganglion, where you'll have a Horner syndrome. These patients tend to get proptosis if it's metastatic to the orbit, as well as lid ecchymosis. The opsic that's noted with neuroblastoma is a perineoplastic process. Histologically, neuroblastoma is one of the blue cell tumors with large nuclei. There are a number of benign neoplasms of the orbit. We've covered capillary hemangioma earlier with the lids. In this section, we'll cover lymphangioma and optic nerve glioma. The other tend to be more rare. Lymphangioma tends to cause an axial proptosis because the tumor is intraconal. They can have hemorrhage into the cyst, and it tends to enlarge during upper respiratory infections. Optic nerve glioma is associated with nerve fibromatosis type 1. They tend to be either stable or very slowly growing. Concern comes when they pass back through the optic canal and impinge on the chiasm. This might be a situation where you might want to treat these patients with chemotherapy or radiation. We're going to cover ectopic tissue in the next few slides. There are a number of ectopic tissues that can affect the orbit, including dermoid cysts, coloboma cyst, which tends to be microphthalmic with a large coloboma cyst, encephalocele and teratomas. Dermoid cyst is probably the most common ectopic tissue in the orbit. It's a choristoma. It's most common orbital tumor in kids. It tends to form at the frontozygomatic suture, although I've seen them at the fronto maxillary suture. I tend to try to get these out before the child is toddling, because if they fall and bump these